Welcome to the February 2025 PD Parlor with Dr. Priya Cardone of UPMC. This is her second of 3 talks on cognition. Thank you very much for your time. Thank you everyone for listening, and please take it away, Dr. Cardone.
All right, thank you so much. Thank you everyone for joining. So if you are new this week and you didn't see my talk last month on general cognitive changes in the elderly, that is on the YouTube channel. So feel free to obviously listen into this, and then you may want to go back to YouTube, watch the general cognitive changes video, and then rewatch this so that more of this kind of makes a little bit more sense in the context of what happens to the brain as it ages. So I have a couple of updates that I forgot to mention in the first one that came to me later. So some other things that affect cognition and affect those age-related wear and tear spots on the brain. One of them is atrial fibrillation, which is an abnormal heart rhythm. This causes basically disrupted blood supply to the brain. It can also cause large or even little small clots that kind of accumulate in the heart if it's not pumping and blood is kind of just sitting stagnant in the heart. Those little clots can break off, go into the brain, cause little micro wear and tear. But if it's a large enough clot, it can go into one of the large blood vessels and cause an actual stroke. So atrial fibrillation is a risk factor. Even if a person is diagnosed with atrial fibrillation at point X, you may never know how long that person might have had atrial fibrillation prior to that. It's just a matter of how obvious was it, how did it get caught, whether it was accidental, or if that patient actually had heart palpitations or they actually were wearing a heart monitor and it picked it up. So again, whatever damage or injury you see that maybe if you attribute to atrial fibrillation, just be aware that that could have been long-standing prior to that being identified and treated. Repeated infections, I forgot to mention this. So repeated urinary tract infections, repeated lung infections, skin infections, orthopedic related surgery infections. So any of these things also mess with the brain. So there's a link, brain bladder, brain gut link. So there is definitely a very real connection there because very common cause of altered mental status or confusion in elderly population, the first thing you check is, are they having a urinary tract infection or some other type of infection? Seasonal affective disorder. So this has become more obvious and prominent. We live in Pittsburgh. There's no sunlight here. The days are very short. The winter is very long. So that's something to be aware of. Separate from depression, but can make depression worse. It's just its own kind of little thing, and it's a little bit more prominent in the winter. So it can cause a little bit of mood changes, reduced energy levels, fatigue, tiredness, just irritability. Something to ask your doctor about if there's a concern for this. And then also little hemorrhages on the brain. So when you have really high blood pressure, it can put a lot of stress on little blood vessels in the brain, causing them to rupture, and that can cause a little micro hemorrhage, meaning a small area of bleed. 1 or 2 doesn't really do anything clinically, but if you have a ton of them or you have a lot of them all over the place, that can contribute to cognitive changes. There's a specific medical condition called amyloidosis. So for this condition, some people's blood vessels in their brain are just a little bit more susceptible to having injury. So they have a lot of little microhemorrhages all throughout the brain, and this can cause cognitive changes. Okay, so today we're going to focus on actual cognitive changes that occur in Parkinson's disease, specifically separate from the regular age-related wear and tear cognitive changes that occur. So there's kind of like different stages. So there's kind of an early stage, a little bit of a middle stage, more towards actual PD dementia stage. So we'll start in the early stage. So the first obvious change that occurs is patients have some difficulty with executive function. So executive function is basically your brain's ability to think of and plan its actions and actually carry out those actions. Somewhere here, maybe a little bit after the early changes, you can have what we call mild cognitive impairment. And this is where patients actually start to be aware of some changes themselves, or it becomes a little bit more obvious to family members. So The different aspects of mild cognitive impairment include reduced attention span, bradyphrenia, which means slowness of thought. The executive function is in here as well. Some changes with language and memory and visuospatial tasks. So we'll go into all of these individually and discuss more details about those. So I'll still stay on the early changes with the executive function. So executive function means the ability to think about what you have to do during your day, plan out your activities, actually execute those behaviors. So it can be even as simple as like when you wake up, you have to know that you have to go to the bathroom, brush your teeth, groom yourself, take your pills, and then planning out the fact that you have to do these, that is executive function. And then actually doing those tasks is executive functioning. Okay, so we'll go into what makes up mild cognitive impairment. So the first portion of memory that's affected here is attention span. So what I frequently hear is I will ask my husband to do 2 or 3 tasks in a row, and he's able to do the first one, but then sort of forgets about the second or third, or doesn't exactly remember what to do. And this is commonly related to reduced attention span. So the brain, when it pays attention to something, it should be able to like space out the attention span to listen to the entire task or listen to the entire instruction and plan out how to do every single one of those. But with PD, some of that goes down. So what I find helpful is to ask patients and family members, if you have to do a complex multiple step task, break it down into a couple of different steps. So for example, I have to go to ask your husband or ask your spouse to go to the grocery store, pick up bread, milk, and eggs, get gas in the car, come back home, pick up the mail. Maybe that's a little bit too much. So we have to either break it down and say, you're gonna go to the grocery store. Here's a list. Can you please get everything on the list? Can you put gas on the list and then come back and get the mail? Breaking it down into individual portions instead of saying, go out, do all the errands and come back. That's a little bit too vague. Okay, the next change that can be seen is called bradyphrenia. Brady means slow, phrenia means thinking. So it just is slower thinking. So if any of you have ever taken a Benadryl, you have experienced bradyphrenia. Benadryl is a common offending factor. It just makes you think a little bit slower. Another way you might have had this is if like you're sleep deprived for a couple of days and then the next day you're just not thinking as fast and you're just not hanging on to every detail as thoroughly as you would have been. So this can present with having slowness of thinking. And then if you try to ask that person a question and they're trying to think of the answer, it might take them a little bit longer to recall the actual answer. If you give them a statement or a command or something to do, again, their ability to process that whole entire task maybe just take a little bit longer. And again, if you've ever taken a Benadryl, you probably know what this is like. So as you're probably starting to see here, a lot of these things overlap. So reduced attention span and slowed thinking, they're all going to be going on sort of together at the same time. All right, executive function. So a little more details about this. This is the ability to think up a plan that needs to be performed, think about an action that needs to be performed, or some task that needs to be accomplished, planning out the different steps of accomplishing this task, managing your time and timing the order of the different portions of the task, and then actually doing those tasks. So, for example, if someone is going to cook a meal and they're making like spaghetti, you have to remember to put water on the stove. That probably takes the longest to boil. You have to get the ingredients out. You have to get sauce out. You have to make sure there's clean dishes. So the ability to think about all the tasks that need to be done to accomplish this task of serving dinner, and then deciding which things need to be done first, which things need to be done last. So for example, you're not gonna like put all the dishes out on the table and then like get out all the ingredients, cut up all the stuff, and then you start to boil your water. Again, that's like an example of executive functioning, maybe not functioning as best as possible, because you could have started that long task first and then done the other task. So just an example there. Switching focus. So this is another thing that comes up commonly. So ability to be doing one task and suddenly you get distracted. Somebody asks you a question, you hear a noise, you hear something on the TV, you switch over to that task, and then your ability to return to the original task goes down a little bit, or you forget that you were even doing a task. So this, if you can imagine, is related to attention span. So did you have, like, what is your attention span on the current task? Are you easily distractible, that you heard some small noise or some other stimulus and you got distracted and you went over and focused your energy on that task? Or are you able to really complete this task, kind of filter out that noise or filter out that stimulus, decide if it really needs your attention or not? Disinhibition. So this is another one. So as you get older, your brain's ability to quash extra movements, extra thoughts, extra statements, it just goes down a little bit. So it's like if you're in a public situation and you see something that's a little bit embarrassing, do you have the ability to not say that out loud or not draw attention to it? Or is that ability kind of reduced and you just kind of say whatever that comes to your mouth, and you say things even though it might be embarrassing to somebody else, and you don't really recognize that that might not have been an appropriate statement? So it's kind of like your filter goes down. So patients' spouses will sometimes notice this prior to the patient observing this. And then, like, the biggest example I always see of this executive function issue is he never uses his walker. She never uses her walker. She always forgets. And I try to counsel patients and family members that do not take that personally. That is, that person's brain does not have a good ability to recognize that they want to walk, but before they walk, they have to remember that they have a hard time walking. Then they have to remember to get their walker. They have to remember how to use it, and then they can walk. But sometimes that circuit is gone. So it's like, I want to walk, I just get up and walk. Didn't think about, or were not able to think about, how can I walk safely? So this is like kind of a contentious point, and people tend to want to blame the patient and say, well, he just doesn't want to use the walker. It's not that. It's not that they don't want to. It's not that they're doing it on purpose. It's not even that they're forgetting. It's just that their brain's ability to recognize the fact that they need an extra 1 or 2 steps prior to walking, it's going down. So one way around this is basically repeated visual cueing without getting angry and upset about it. It's just making sure the walker is always within the visual field. Put a big bow on it, put a light on it, put a sound on it, make it obvious so that you are sort of forced to remember that it's there rather than having to remember that it's there. It's already there, you see it and recognize it and use it. All right, so language. So as people get older, they have brain farts, and you say, I can't think of that word. It's right on the tip of my tongue. I just cannot get that one word out. You go about your business, you talk about something else, you say some related words, and then it comes to you. So this is what we call word finding difficulty. And this is actually a normal part of aging. As we discussed in my original video, when you have a lot of age-related wear and tear, those little white spots on the brain, you're trying to get a memory from over here to travel all the way over here, form a thought, then you're trying to get it to this part of the brain to get out of the mouth. If that message keeps hitting potholes, it keeps bouncing around. So it takes a longer time to get all the way to the actual language center of the brain. So that's one of the reasons for this. But it's also a symptom of the Parkinson's disease cognitive changes. So it's kind of like something's on the tip of your tongue. You cannot get that same exact word out, but you can get other words out that are related to that word. Or somebody else says the word and you agree that that's the word. So this is some of that. Naming specific items, this is an issue here. You can have some difficulty coming up with the exact name or word of that specific item. Sometimes you also just have the sensation of information overload where you're trying to process way too many things at once, and that confuses and slows the brain down so that you're not able to get your words out. So one thing you can do is basically just slow down a little, try to distract, try to talk about something else, and wait for that word to come back to you. Okay, so memory. So memory is a huge topic. Memory involves your short-term, your long-term memory.
I don't get why this is.
Hello? Need help? Okay, memory involves your brain's ability to learn new information, and it involves being able to
Go into my headphones.
retrieve that information on demand at the moment that you need it.
I'm not staying here, so don't worry about it right now. You
Okay.
can fiddle with it later.
All right, I'm sorry.
That's okay. Don't be sorry. It's fine.
Okay, let me mute people. There you go. Okay. All right. Back to our presentation. Oops. Okay. So the ways that this impacts patients who have Parkinson's disease. Short-term memory is you have to remember to take your meds every 3 hours, every 4 hours. Then if you have a hard time remembering that, you're like, oh, did I take that tablet? Did I not take it? And when patients come and they say my meds aren't working, one of the first things we ask is like, are you actually remembering to take them? Are you having a hard time remembering to take them? Is there confusion about which ones you've taken? And that's difficult. Like if you have a whole bunch of medications to take, they're all in their own little bottles, and you take one, later on, you can't really remember, did you take it or not? The easier way is that if they're all organized by day in a pill box based on times, and then if you can't remember if you took it, you go back to the box. If it's there, you obviously did not take it. But if it's not there, then you know that you took it. So we try to encourage patients to use some devices like this to help take away the burden of having to remember every single thing. Learning new information. So everybody, thinks about can do a Sudoku puzzle, you can do crossword puzzles, word searches, thinking that will help the brain. It doesn't actually help as much as we think it is. What is actually proven to improve cognitive function is actually learning new information, because that forces the brain to create new memories, and creates new neuronal connections and new synapses in the part of the brain that is responsible for memory, the bulk of which is called the hippocampus. So learning actual new information is what the best thing that you can do for yourself. Recalling information on demand. So when you're stressed, nervous, anxious, someone asks you a question, you're trying to come up with someone's name, you're trying to come up with a specific detail. That can be a little bit challenging for some patients. So again, slowing down, trying to distract, trying to use other words to jog your memory. And again, the part of the reason of this slowing down is chronic changes in the hippocampus, which is where memories, long-term memories, are stored, and then trying to travel there to retrieve those memories and get them to the part of the brain that allows you to actually speak those memories or speak those words out. So it's a couple steps of a process. And if the brain keeps if the messages keep hitting potholes along the way, that memory or that thought comes out a little bit slower, maybe a little disorganized, maybe missing a little bit of pieces. So patients also typically say that long-term memory is typically spared in the beginning. So it's more of I told my husband this, and then 5 minutes later he asked me that question again. That's a short-term memory issue. But if I ask him who did he go to high school with, who was his teacher in high school or something like that, that's a long-term memory, because those are coded in a different portion of the brain, where memories are coded a little bit more permanently in the hippocampus rather than in this frontal lobe working memory. Working memory is sort of what you can call short-term memory, things that your brain can hold temporarily but doesn't need to hold on to permanently, because that would cause way too much baggage. So for example, you are going to the grocery store and you need milk, eggs, lettuce, bread. You can put that in your working memory, hold on to it temporarily, get to the store, use those memories, put those things in your cart, and then that information can leave your brain. You don't need to remember 30 years later that you went to the store one day and got milk and bread and eggs. You just used those memories and then they're gone. And that clears up space, which is good. Again, thinking of your brain like a computer, you've got browsers that are running. Those are your short-term memory, your working memory. And then as and when you do a browser or complete a task on a browser, you can close that browser and then everything else runs faster. But then there's also long-term documents like tax files or records or something like that. That's on the hard drive. That's there permanently. However, going to get those takes a little bit more work than just opening a browser on the bottom. Use what you need, close that browser down, minimize it or close it all together, and it's gone. That's quick. That's here and there and it's gone. But the hard drive, more permanently coded stuff, but harder to get to. Okay, visuospatial. This is the weird one. So some of my questions geared towards patients with a Parkinson plus syndrome. Some weird questions I have to ask sometimes. When you're eating food, are you spilling food everywhere? Is it spilling on your shirt? You can't tell where the spoon is in your hand. You can't tell where the plate is. You're like reaching around. You're sloppy and you're messy and you're spilling way too much stuff. That tells me there's something going on with the visual spatial awareness. It means like your brain's ability to see a stimulus in front of you, see an object in front of you, their brain's ability to tell another body part how to manipulate something to get to the target area and then move to another body part, those pathways are a little bit off. So spatial awareness, meaning hard time judging where you are in relation to your surroundings, in relation to other people around you. So common thing I hear is like, oh, he's clumsy all the time. He keeps bumping his head, bumping his arms. He's just like not aware of where his body is in relation to an object or furniture. Being able to judge what else is in your environment, safety issues, like if you're driving a car, are you able to maintain spatial awareness of where the other cars are, where people are, etc. Another weird one is a reduced contrast sensitivity to colors. So for example, if patients have like a piece of white bread on a white plate, that's a little challenging, as opposed to if it was like a white piece of white bread on a red plate or something like that. It's a little easier to judge and judge the distance between the plate, the edge of the plate, the food item, your hand. Navigation. So are you getting lost while driving? Are you getting lost while driving familiar places or new places? Like nobody is expected to navigate new places totally brand new, but is it regular places that you're going all the time, like the grocery store, the doctor's office, the pharmacy, and now you're having a hard time? Visual misperceptions and illusions. So this one's tricky too. This is can be scary for patients. So there's different categories of visual misinterpretations that can occur with Parkinson's disease. The most obvious scary one is hallucinations, and that is when a person is completely awake and they see a fully formed figure. It's a person, it's a tree, it's an animal, it's a little kid, it's bugs on the floor, it's water on the floor, it's an actual thing. That's a hallucination. Illusions are a little bit tricky, and misperceptions are a little tricky. So one example of an illusion is you look at a clock face, but you think it's a person's face. Another example is you see a blanket on the sofa and you think it's a person. So like there is definitely still something there, but you're perceiving it as something that it's not. Another one is seeing figures. So it's not a fully formed hallucination of a person, but it's just like a figure out of the corner of your eye, a shadow out of the corner of your eye. You turn and there's nobody actually there. And then finally, the other little bit scary one is feeling that there may be somebody in bed with you and there's really nobody in bed with you, to the point of like actually reaching out, touching the covers, checking under the covers. And that one can be a little bit unsettling for patients. All right, so sorry, I guess I got ahead of myself. The middle stages here is where we're seeing things like hallucinations, visual illusions, misperceptions. Misperceptions can be visual and cognitive. So delusions and paranoia, this is a big one. So when patients start to say like, I'm thinking my spouse is cheating on me, or I'm thinking someone is watching me and they're not, this is an example of delusion and paranoia. And that's a spectrum. So there are some like on the milder end of the spectrum where you can talk them out of it. They are able to justify to themselves that that's not real. And then there's the point where you cannot justify. You truly do believe your spouse is cheating on you. You truly believe someone is taking money out of your bank account, and that can be very problematic. When we get into this category, number one, we look at medication side effect. Are we on medications that increase the risk of this? So the dopamine agonists like Mirapex, pramipexole, those have a higher chance of causing these paranoid delusions, hallucinations, these cognitive behavioral changes. So if that's the case, we get rid of those first. We slowly back down on other medications and see if we can get rid of it if it's a side effect. If we get rid of meds and it's not there, then it's not a medication side effect. Then it's an actual Parkinson's disease symptom or progression of the disease. Agitation. So the witching hour is like 6 to 9-ish, depending on each patient, having a hard time in the evenings. Sundowning, gets dark, patients get confused, they get a little bit agitated. So these are tricky times to navigate. So we use a combination of medications, gentle redirection, earlier bedtime, distracting activities. One thing I forgot to put in here, imposter syndrome. So imposter syndrome is kind of scary again. So imposter syndrome is when a patient believes that there are two versions of another person, like typically your spouse. So they'll say like, I have my husband and then there's the other husband or like the other man. And patients can become very scared of this and get confused like why they have two husbands or why they have two wives and which is the real one and think that the real one is not the real one and that the real one is the one trying to hurt them and that they're trying to get back to the other spouse. So be aware of something like this and make sure you discuss with your doctor if somebody that you know who has Parkinson's disease is starting to say some symptoms like these. So one more note about hallucinations. So hallucinations, they can also just be benign. A lot of patients are totally aware that they're having a hallucination and they know it's a hallucination and they are not bothered by it. So my rule of thumb is if you are not bothered by it, I'm not bothered by it. The point where we reach when we discuss treatment or changing actual management to reduce them is if that hallucination is scaring the patient, if the hallucination is causing a safety issue for the patient, or if the hallucination is causing a safety issue for a family member. So for example, if a patient is seeing hallucinations of people coming into the house and actually calling the police repeatedly, calling 911, obtaining weapons to try to protect themselves, that's an issue. If a patient sees a family member and perceives them as the imposter or a not a family member, just like an intruder, and they're getting a weapon and trying to protect themselves or injure that person, that is a safety issue. So that's where we treat these. Or if it is something very scary and the patient is distressed by it, then we treat them. But if it's benign, I see puppies, I see cats, I see little people, I watch a TV show, we just leave those be for now. Okay, so again, cognitive changes, and again, I already discussed this in the cognitive lecture, but this is worth reviewing. What do we do when patients start to complain of cognitive changes? So we get an updated picture of the brain. Again, depending on that patient, depending on how long ago you had a picture of the brain, if something has drastically changed, I have a low threshold for repeating MRI because I like to see if you have had new age-related wear and tear, new shrinkage. Did you have a stroke? Did you have a bleed somewhere? Do you have some other new unexpected changes that we need to deal with? Depending on whether or not they have had blood vessel imaging, we get that as well. If there's a question of like lightheadedness, dizziness all the time that you think is contributing to cognitive changes, we look at blood vessels, make sure everything's good and open and the brain is getting good blood supply. Then we repeat the metabolic testing, again, depending on how recently it was checked, what were the findings at that time and any interventions that were needed. Periodically, we check B12 levels, iron levels, ferritin levels, thyroid levels, vitamin D, which now has evidence-based link towards cognitive changes. B1, which is thiamine. So if patients have a problem with drinking too much alcohol, or they've had history of gastric bypass, or they have some type of absorption issue in their gut, B1 is one of the first ones to go down low, and that can cause encephalopathy or confusion. And anything else that's pertinent to that particular patient. Then vision and audiology testing. So if you are having visual hallucinations or illusions or decreased vision, kind of good idea to have a basic eye exam. Make sure it's not just a basic eye problem, because if it's an eyeball problem, then that is treated or addressed accordingly by an ophthalmologist. If it is not an eyeball problem, then we say, okay, it's probably a brain problem, and then we treat that accordingly. If we're having auditory hallucinations, is it because there really is a sound stimulus and you are not perceiving it correctly, or are you truly having an auditory hallucination? In which case, it's good to have a baseline hearing exam, but also potentially a brainwave test or EEG to check for possibility of seizures, because seizures can cause auditory hallucinations commonly as well. And then, of course, my big one, home sleep test. So untreated sleep apnea makes everything worse, but not just sleep apnea. There are other sleep disorders that occur with Parkinson's disease. So REM behavior disorder, periodic limb movement disorder, all of these things can affect sleep quality, which then in turn affect cognition throughout the day. So the home sleep test usually picks up all of this, or at least tells you a hint that something is wrong and that patient needs a more in-depth sleep study in the hospital. But I try to start with the home sleep test because you're in your own bed at least, and it's quite non-invasive and uncumbersome, and you'll have a best chance of having an actual accurate test that I can use. Okay, so then if patients continue to have cognitive symptoms, after I have identified all of the risk factors and actually treated them as best as possible, optimized all your risk factors, so low iron, low B12, you have sleep apnea, we got you on a CPAP and you've been using that for at least 6 months, or you're trying your best to use that. You had depression or anxiety, we treated that. All of these extraneous factors are removed. Then we send you in for the formal cognitive testing. And again, I'm sorry, we don't do that unless vision issues and hearing issues are corrected, because if you cannot see well enough, you are not going to be able to participate in the test. If you cannot hear, you will not be able to participate well enough in the formal cognitive testing to be able to use the results in a usable degree, basically. So the formal cognitive testing is quite long. It's a couple of hours. There's a few people that I truly trust, and I like to send people to the UPMC Neuropsychology Department because they do a very, very thorough exam to put together all of the pieces that we talked about. So the attention, the recall timing, the visual spatial orientation, the language, the math, the problem solving skills, and they gear it towards the Parkinson's patient specifically if they know that that patient has Parkinson's, as opposed to just a general cognitive exam. So it's tailored towards what are you looking for. And after they collect all of their data, they kind of put it together into somewhat of a label most of the time. And usually my label in my head is the same as the label that comes up on the cognitive testing. So then I feel more confident that that's most likely accurate. So the formal cognitive testing can tell somebody, is your cognition completely normal? Are you meeting the criteria for Parkinson's disease dementia? Are you somewhere in the middle with mild or moderate cognitive impairment? Or are you somewhere else with a different named dementia, such as frontotemporal dementia, dementia with Lewy body, Alzheimer's dementia? Or are you here, but depression is making you look like you're here? Are you here and anxiety is making you look like you're here? Are you here and medication side effect is, or untreated sleep apnea, or whatever other issues are making you look worse than you really are? So that helps me know that I'm not missing any other pieces, or tells me if there are pieces that are confounding that person's memory that I can actually treat. Another example is like it really picks up very well on attention span. So ADD or ADHD are common causes of poor cognition, but it's not actually poor cognition. It's actually just reduced attention span. So then I can kind of counsel the patient and say, this is what was found. You seem to have a reduced attention span. So that, number one, alleviates some of that patient's concern, and it helps them feel a little more confident that they maybe have something that's a treatable domain and not actual dementia or cognitive impairment. And then it helps them kind of tailor the treatment plan based on what was actually found in this cognitive testing. So once we do all of this, we get the formal cognitive testing, we have the results, then what do we do with those results? So a couple of options. Number one, I always offer cognitive rehab to patients. Cognitive rehab is like physical therapy for your brain. It's done by a speech therapist typically. It's best done after that patient has already had the cognitive testing, so the speech therapist can read the test results and figure out and know where the deficiencies are, and then tailor that cognitive rehab to those specific deficiencies. So for example, if a patient has difficulty with multiple step tasks, they can be taught and encouraged how to make a list and keep a list of items or list of tasks that need to be done by, and also breaking them down into smaller portions and then like crossing off that portion and then you're done, rather than just trying to tackle a whole large task every day or whatever it is that needs to be done throughout the day, breaking it into smaller pieces. Okay, the next thing that you can do is physical and occupational therapy. So physical therapy is sort of can sometimes be a little bit of a social visit. So a lot of times what we see, people are just bored and they're bored in their house and then they sleep all day because they don't have anything else to do. And then they're awake all night and then they don't get good sleep and that affects their cognition. Physical deconditioning also sort of indirectly affects cognition. So the physical therapy serves as not only a physical rehab, but also a little bit of a cognitive rehab because you are forced to get up, get dressed, groom yourself, go out to the physical therapy, whether that involves you driving yourself or a family member driving you, but it's again some social interaction. You get there, you have an actual visit with another person, which is a one-on-one social and physical visit. You do some task, and then you have a sense of completion and a sense of accomplishment that you have completed that physical therapy visit, and then you go home. So that is more than just that 20 minutes or 30 minutes in the therapy. It's way more than that. So it helps with the whole brain kind of just being perked up and having something to do on the schedule for that day. Occupational therapy is more geared towards fine motor tasks or activities of daily living. So if there are tasks that are getting difficult at home, such as cooking a meal, which is a cognitive and physical task, the occupational therapy can help come up with ways of that task being broken down into smaller, more manageable pieces, and then practicing doing those pieces safely. Speech therapy, again, goes in with that cognitive rehab, especially if there are big issues with like difficulty swallowing or getting the words out and having word finding difficulty. We can learn ways to kind of circumvent that. Medication options and lifestyle modifications. I think I have a slide on medications, so I'll come to that in a minute. But lifestyle modifications, again, making sure you have a schedule during the day that you actually follow and you do some specific tasks each day. Trying to limit napping and sleeping throughout the day so that you are awake during the day and you sleep at night. Making sure we are having good social and physical activity because loneliness is actually a large and very prominent risk factor for cognitive impairment. So if you're not interacting with people, you become socially isolated, withdrawn, and then the brain's cognitive ability does take reduction. So making sure that we are in some social activities and that we have transportation and we have a way to get there safely. Okay. All right, so here we are at medications. So medications for cognitive impairment is a little tricky because number one, you can't just give someone medication without having identified what are the causes of their cognitive impairment. So that's the purpose of doing all of this other testing, the formal cognitive testing, the pictures, the lab work. You have to really know what you're treating. So again, risk factors have all been optimized. You've sent that person for formal cognitive testing. You have mild cognitive impairment or something in the Parkinson's disease dementia realm. What can you do? So rivastigmine is one of the medications that can be used. This is an acetylcholinesterase inhibitor. So basically what it does is allows a certain neurotransmitter to kind of hang around a little bit longer in that connection area between first and second neuron. So in that mechanism, it can help to improve cognition a little bit. It helps kind of clear up the brain a little bit, help with the foggy thinking a little bit. For my patients who are having hallucinations that are starting to become bothersome, this is one I reach for typically. For my patients who have dementia with Lewy body, this is one I reach for. And I'm going to do another lecture on dementia with Lewy body and some of the severe versions of Parkinson's disease, dementia, psychosis, and dementia with Lewy body. So that'll be in the next lecture. So we'll kind of come back to this a little bit more. Rivastigmine comes in a patch and a capsule. It's a lot of different dosing options, so it's quite easily titratable and adjustable. Pimavanserin, so this is a newish medication. It came out when I was in residency, so it's been like maybe 4 or 5 years, not a super new drug. It's technically only approved for Parkinson's disease dementia, but keeping in mind that that is a clinical diagnosis, sometimes it is extrapolated to other stuff because there's no one test that proves someone has PD dementia or not. So it's a matter of like documentation. So this is a once-a-day dosing tablet that can be used to reduce symptoms of PD dementia, helps reduce the the level of cognitive impairment, helps reduce psychosis. It can reduce the hallucinations. Coffee. So a lot of my primary, very, very common complaint in Parkinson's disease is fatigue. And the easiest thing you can do, again, if you made sure that that person doesn't have sleep apnea, you've treated any other things, and they're just tired, little bit of coffee goes a long way. So 1 cup in the morning, another potential cup early afternoon. I do recommend that sometimes for people, and sometimes that's just enough to get them throughout the day, give them a little boost of energy and kind of go about your day. Stimulants, I'm not a huge fan of. Stimulants are tricky again. You have to use them carefully depending on what that patient actually has. So if they actually have narcolepsy, which is a sleep disorder, and then you can use a stimulant. If they have multiple sclerosis that causes fatigue, then you can use a stimulant. I pretty much try to avoid this in my Parkinson's disease patient because I always find some other issue that I can treat that is contributing to their fatigue that I don't need to go to a stimulant. Memantine and Aricept. So these are older medications. These are technically for Alzheimer's dementia. However, pretty much all neurologists will be happy to try them for any other forms of cognitive impairment because they're also relatively benign, unless there's a few caveats there. But basically, it's that if that person has cognitive impairment, you've done everything else you can try either one or both of these medications. And if that patient feels better and their cognition improves objectively or subjectively, you can keep them on it. If it does not improve and or they have side effects, you just kind of get rid of it. So memantine side effects, nothing really specific that I've observed. The Aricept does have a known common side effect of GI upset, diarrhea. So if that occurs, you would just stop the medication. There is a specific form of dementia called frontotemporal dementia. If those patients start Aricept, typically there's a worsening. So you would try to make sure that that person does not have frontotemporal dementia before you put them on Aricept. And it's a little hard. You have to put a lot of pieces together to try to find a diagnosis because there's really no one good test for any of these forms of dementia. Okay, so that's all I have for today. So I guess we can open it up for questions. Oops, sorry. Have you not been seeing the slides for a very long time? Oh, no.
No, but we heard you.
Here, I can go through the last couple ones.
Okay.
Yeah. So the do you see medications here?
No.
No, that's weird. Okay, I don't know what to do about that. I'm sorry, because that's on my screen, so I guess it's just a maybe a glitch or something. But it'll be on the. I'll try to put it back up there. Can you see my screen now?
No, we can
Okay.
just see you. We haven't been able to see it the whole time.
Oh
I
my
sent
gosh,
you a
I'm so
message.
sorry.
That's okay.
I am so very sorry. Oh, I did not share it. Okay. I'll go through things real quickly again. All right. So the cognitive changes basically were broken down into, can you see the slides now?
Yes.
Okay. So we're broken down into the early stages and then the mild cognitive impairment stages. Mild cognitive impairment is broken down into reduced attention span, slowness of thinking, executive functioning, meaning ability to think of a task that needs to be done and actually execute and perform that task. Language, meaning word finding difficulty, naming items and coming up with words on the tip of your tongue. Memory, meaning short and long-term memory and the ability to recall information. Visual spatial awareness, meaning being aware of what is around you and being able to interact accurately with the objects that are in your visual field. Then in the middle stages is where we start to get things like hallucinations or visual illusions, delusions, paranoia, and agitation, and behavioral changes. So we always get all the basic testing that we get for anybody with any cognitive impairment, meaning pictures, blood tests, and then functional testing like vision and hearing tests, and home sleep tests to evaluate for apnea. After we identify and treat all risk factors, we can send patients to formal cognitive testing to get more details and try to label their level of cognitive impairment. Then for treatment options, we can do cognitive rehabilitation, medications, and lifestyle changes. Medications we discussed are rivastigmine, pimavanserin. Those are the pimavanserin is for Parkinson's disease dementia. Rivastigmine is for any cognitive changes that can occur along the pathway of Parkinson's disease or dementia with Lewy body. And that was about it that I have for today.
So if you
I try not to put too much on the slides because I just want people to listen rather than read slides anyway.
If you have a
Okay.
question, you can unmute yourself and ask it, or you can type it in the chat.
Okay, I have a question. Have you been talking about worst case scenarios?
I have not. What do we define as worst case scenario? That means something different to everyone.
Well, is Parkinson dementia a given for anybody who has Parkinson's?
No, not necessarily. It just because you have Parkinson's does not mean you automatically will get dementia. Again, it's a combination of all the risk factors you may have had prior to the Parkinson's disease that just normally come with aging and your actual Parkinson's disease. And depending on how early those risk factors are identified and treated to try to reduce their effect.
But that's good to know.
Hmm?
Yeah, thank you.
Dr. Cardone, is there a certain percentage that you've heard? It seems to vary a bit in terms of how many may develop Parkinson's disease dementia
I
approximately.
don't really know off the top of my head. I'm sorry. I'm really bad with numbers, to be honest. I never think about numbers too much because it's like every single patient is just different, and I just assume that everybody can have anything. And like I said, it's really hard to differentiate the PD dementia versus any other cognitive changes or dementia they may have had prior to or along with just from the process of aging, and it depends on all the other risk factors people have. So I'm sorry, no. The point where I get to talking about PD dementia with a patient is, however, is when they themselves endorse that they are having some cognitive complaints, or if I obviously pick up something in the visit, like if I'm trying to talk to a patient and they can't answer any of their questions, and they keep turning to their spouse or family member who has to provide all of the information. And up until then, if we have not discussed cognitive stuff, that would be like a time that I discuss that. I chat a lot with patients during the visit, and it seems like it's small talk, but it's actually my trying to figure out if they are having normal conversation or normal cognition, without telling them that, because then everybody gets nervous and that's not really accurate. So it's easier to just chat about regular day-to-day lifestyle stuff and see how quickly people come up with appropriate answers, and then use that as my judgment whether they need some cognitive testing or not. Does anybody have any other questions?
No. No,
Yeah, okay.
actually, I was kind of concerned, as you talked, that that it might be a given that a person would develop, like with the stages of death or whatever, that with the stages of Parkinson, you automatically develop dementia, but you're saying that's not the case.
No, not
It's
necessarily.
possible. It's a
What?
possible. It's a possible thing that could happen.
Yeah,
But
everything is
definite.
possible. Yeah, everything is possible, but it doesn't mean that it's definite.
Okay. Yeah, but that's good to know.
Yeah,
Yeah, thank you.
you're welcome.
And I know a lot of people on this call and in our community exercise regularly, which can help with your cognition. So keep in the social connections. So keep up with that.
Yeah.
Yeah.
You're right.
Yeah, but thank you. That's good advice.
Good. Okay. I guess we can wrap up. Then if nobody has any other questions, again, if you ever need anything, you're interested in finding out more, please touch base with me or Casey, and she usually communicates questions back to me. So I'll try to address them as much as I can in the next video.
Thank you.
So in March, same date, right?
Yeah. So I'm
Dr.
planning to do, what is the date? What is the date going to be in March?
March 20th.
Yeah, so I'm planning to do like PD psychosis, dementia with Lewy body, PD dementia, which is I'm still like, I didn't get to that yet. I did regular cognitive changes where I did mild cognitive Parkinson's disease cognitive changes, and then PD dementia, PD psychosis, and dementia with Lewy body are kind of over here. So I'll do those next time.
And if anyone would like your slides, could they email
Yeah.
me? Okay.
Yeah,
So if you'd
sure.
like the slides, just send me an email and I'll get those to you. Thank you, Dr. Cardone. We'll see you on March 20th to conclude the cognition series, and then Dr. Cardone will do some of the kind of overviews again.
Mhm.
Okay.
Okay.
Thank you. Thank you.
Super.
Bye,
Thank you.
everybody.
Bye-bye.
Take good care.